Good evening, everyone. We'll jump right into the questions tonight. Let you guys get watching the USA-Belgium game in just a little bit. Hope you guys enjoyed the 4th of July. I got out to the woods, did some hiking, did some thinking, had some interesting things coming along with Apollo Cardiology. So first question up tonight, can you reduce your CT coronary calcium score? Short answer is you really should not be trying to. You should be trying to stabilize it and figure out why you have an abnormal CT coronary calcium score. The score should be 0 for as many decades as possible. I've seen patients in their 80s with scores of 0, seen patients in their 30s with scores of nearly 1,400. So once you have an abnormal score, that helps risk stratify you. You need to figure out, is it an issue with your endothelial lining? Or do you have a lot of oxidative stress or inflammation? Or do you have lipoprotein A or some other genetic reason why you have high atherosclerotic burden? Stabilizing plaque is not hard. That's what we do all day long at Apollo Cardiology. But will the score go down? Not necessarily. I've seen some scores go down if their scores are generally in the low double digits, but you just generally don't want to see the CT coronary calcium score test increasing more than 5% a year. If you don't change what you're doing, oftentimes the calcium score test will increase 20% a year. But once you have an abnormal score, I usually recommend people consider using a CT coronary angiogram instead. You can use AI plaque analysis to evaluate how much soft plaque you still have. It's the soft plaque that is more risky at causing heart attacks. The soft plaque is what ruptures and the blood clots. The hard calcified plaque that shows up in a calcium score test is stable. But the more calcium you have, the more soft plaque you generally have. Next question up tonight. Somebody says that they're on a statin, but their calcium score test is increasing by 100. Is this a concern? Any benefit to a CT coronary angiogram? So this piggybacks onto the previous question. Oftentimes, once your calcium score is abnormal, if you add a statin, the calcium score test tends to increase as you start to delipidate and start to calcify the plaque. The plaque can shrink. You're shrinking the salt plaque, but oftentimes the salt plaque will start to calcify. That stabilizes the plaque, makes it less prone to rupturing, less likely to have a heart attack. So if you have a calcium score test that's abnormal, start a statin. Almost always expect your calcium score test to go up. That is not a bad sign. It's usually a stabilizing function. So if you really want to know, are you shrinking the salt plaque? You need to do the CT coronary angiogram to see that part. Is there any benefit to monitoring glycemic load for cardiovascular health? I don't know exactly, do you mean like glycemic index or monitoring cardiometabolic health? The short answer is yes. Elevated glucose, elevated insulin are some of the biggest drivers to the damage of the endothelial glycocalyx. If you damage that protective gel coating, you're off to the races to potentially developing plaque in the arteries. So yes, on every patient, I check their hemoglobin A1C, their fasting insulin, their HOMO-IR score. You can also look at their lipoproteins and look at their triglycerides, their HDL fraction, small dense LDL, VLDLs. Again, idea is the person insulin resistant. If you still have questions, you can use a Stello device to a continuous glucose monitor and find out, do you have excursions of blood sugar over 140? That's about the cut point that you start damaging the glycocalyx if you're persistently greater than 140. But yes, this is part of the things I was thinking about this weekend, is how to monitor your cardiovascular health at home. And that is something that we'll be talking about soon. Question, why do I not recommend vitamin D supplements? That is not true. I do on occasion. It does depend. But vitamin D is a hormone, and you make it by sun exposure. UVB sunlight hits the skin. This cholesterol in the skin is sulfated. That sulfated cholesterol goes to the liver and ultimately the kidney to become the active forms. Taking oral vitamin D does not activate the vitamin D as the same way that sun exposure does. You also make 200 to 300 other compounds when UVB light interacts with your skin that you do not get from a pill. So that's why I don't recommend a vitamin D pill by itself. Also, if you take vitamin D by itself, you generally need to take vitamin K2. If you do not, you could get yourself in trouble with hypercalcemia or hypervitaminosis D. Definitely seen people give themselves kidney stones. Suspected people have increased their calcium score test when they took too much oral vitamin D. It's a hormone. If you use too much, you definitely can hurt yourself. That's why I don't blankly recommend vitamin D supplements to everybody. It's test, don't guess. But I'm generally shooting for a level between 40 and 80 with any patients with cardiovascular disease. Next question, will serrapeptase and omega-3 have a similar action to aspirin? Would that be an option instead? It depends on what you're trying to, quote, utilize it for. Aspirin is an antiplatelet therapy used in patients who've had previous cardiac events, heart attacks, strokes, stents, bypass surgery. Aspirin prevents the platelets from clumping together, reduces the risk of repeated cardiac events. Omega-3s do have some, quote, blood thinning properties, but does not replace aspirin. And serrapeptase is mainly to break up fibrin, also not a replacement to aspirin. Generally would not recommend combining serrapeptase and aspirin. There's case reports with nattokinase and aspirin that are together contributing to intracerebral hemorrhaging or bleeding in the brain. Very bad, potentially fatal. So you do not want to use serrapeptase and aspirin unless you're working with somebody who understands the risk benefits of that. So generally, they're not a replacement. And then the last pre-submitted question, and if anybody has a question that they want to drop in the comments, I'll try to answer those as well. Is ApoB a significant marker, one of the most important to follow concerning cardiovascular health? Yes, but a caveat, 300 to 400 different things contribute to plaque in the arteries. ApoB containing particles are necessary but not sufficient to develop plaque in the arteries. That being said, it is a number that I monitor in every patient. It's the best risk predictor from a lipid-centric model. But you have to look at the health of the arteries in totality, not just what's floating through the blood. So if you have significant plaque in your arteries, confirmed by carotid scans, calcium scores, clearly scans, previous cardiac events, you generally want an ApoB under 70, optimally probably under 55. ApoB is a protein that's on the outside of all the atherogenic or plaque-forming particles. So it's on the outside of your LDL, your VLDL, your ILDL, and your LPA if you have high serum levels of LPA. 20% of the population has high levels of LPLA. LPLA can double, maybe triple your risk of developing plaque in your arteries. So the analogy I often use with the patients is that the lipoproteins are like a tennis ball, filling up full of cholesterol, triglycerides, phospholipids, and those fat-soluble vitamins, A, D, E, and K. The ApoB is like the white stripe on the tennis ball that holds that thing together in the sphere, and ApoB acts like a key to bind into different receptors. So if you count up the ApoBs, you're counting up how many atherogenic or plaque-forming particles are in your blood. So it is something that should be monitored, but I always kind of break it into 3 buckets. You need to also look at what's affecting your nitric oxide pathways and potentially damaging the endothelial glycocalyx. A couple short things can be uric acid, homocysteine, ADMA, urine microalbumin creatinine. Second, you have to look at how much oxidative stress and inflammation you have. HSRP, LP-PLA activity, myeloperoxidase, OXLDL, OXPLA ApoB, F2 prostate creatinine. Multiple labs can look at, do you have a lot of fire or oxidative stress in the arteries? If you have that cocktail with endothelial dysfunction plus high ApoB, you have the perfect recipe to potentially have more and more plaque being distributed in your 60,000 miles of blood vessels. So yes, track it in everybody, but is it the most significant? Not the most significant. I would look at the health of the endothelial function is the most significant, in my opinion. All right, what can cause chest pain during exercise? So I'm a doctor. I'm not your doctor, unless you see me at Apollo Cardiology. So everything I'm saying here is for general educational purposes. But if somebody's having chest pain during exercise, this probably needs a workup with your actual local doctor. Cardiac chest pain can be due to ischemic issues. You might not have enough blood flow in the major coronary arteries. It could be an issue with the microcirculation. Women tend to have more risk of microvascular angina. It can be due to a blood clot in the lungs, pulmonary embolism. It could be due to a pneumothorax, uncommon. And it could be due to an aortic dissection, tearing of the aorta. Very uncommon that it's going to go away and only show up with exercise. It could be asthma. It could be acid reflux, where you're having esophageal spasms. So this is something that would need to know what the other risk factors are. What are the other precipitating factors? What is the quality of the chest pain? How long does it last? What relieves it, if anything? And that will help guide towards, okay, is this more likely cardiac or non-cardiac source of chest discomfort? All right. Well, I think those are the questions for the week. All the archives are going to stay on Instagram. They usually are here for at least a month, but the long form storage forms. These essentially, those go over to my YouTube channel, which is just drtwyman.tv forwards to the at Dr. Twyman page. I also have a school community where I do monthly AMAs that go for an hour, and we're going back and forth through things live. You can do video with those AMAs. We've done long form case studies, gone through people's genetic reports, their labs, their imaging, and said, this is what's going on with their vascular health. This is the lifestyle interventions you can use. These are the medication supplements that will work best for them based off their pharmacogenomics and their wishes. I have courses on there, how to read your own labs, what tests you need to consider to become heart attack proof. If you're ever interested in, going deeper down the rabbit hole of vascular health and working on to continue to be heart attack proof, that's the name of the group, Becoming Heart Attack Proof on the School Community. drtwyman.com/school, free 7-day trial. This Friday, 1 p.m. Central Time. I'm going to be doing one of those Ask Me Anythings. So if you're interested, check it out. Otherwise, every Monday, 6 p.m. Central Time, I'm here answering your guys' questions. Monday morning, I put the box up in my story. First come, first serve. People submit their questions, I answer them in the order received. If you join live, drop your question in the comments. Happy to answer for you. So hope you guys had a great week. I'll be seeing you next Monday time.